All right. Good morning. Today's discussion is going to be in how we actually put patients to sleep in the operating room. We actually, what we call induce patients. That's a proper terminology. What you're doing is you're transitioning very rapidly from an awake state into a very deep level of an anesthetic where you can actually do procedures like an intubation with either minimal or no muscle relaxation at all. You can actually do these things. So we'll start with the first agent, which is talk about propofol, and we'll talk about etomidate and then ketamine, and then we'll talk about dexetomidine, which is the last one. We'll go over pretty much every single one. We'll discuss commercial preparations of the medications, because they do, even though the medication itself functions, the actual preparation and how it's made can actually change how you actually deliver the medication, and it also has significant associated complications with sometimes the actual preparation. Then we'll talk about the mechanisms of action, pharmacokinetics, clinical uses, and then some of the effects on organ systems, which can make you decide if you should use a drug or you should not. And then we'll talk about side effects. And unfortunately, there is no perfect anesthetic induction agent. If there was, then everything else would be off the board, and that's all we'd use. Instead, you got to make a decision every time: which drug should I use in this situation? What makes it most appropriate for this situation? And you got to be able to know all these drugs by heart, and so you can make the safest choice for that patient. And the first one is the propofol, also known as Diprovan. It's pretty different than all these sedative hypnotics. It's composed of basically two components. It's got the phenol ring, which is in the middle, and attached to it on each side in the 2 and 6 position of the phenol ring is isopropyl group. Okay? So the actual name for propofol is 2,6-diisopropyl phenol, and the way you remember it, if anybody ever asks you, okay, it's propo, which is propylene, is the red, okay, and the phenol. F usually starts for PHE in chemistry, so a lot of times you'll see a word, so you can actually pick it out as propofol, is propylphenol. The induction dose that we give is anywhere between 1.5 to 2.5 milligrams IV, and we push it pretty quickly, over 15 seconds or less. And you can expect the one-arm effect to be around 30 seconds. So that person will be induced if you give it a big enough dose. Now, it's very, very consistent, which is really nice about this drug. It's not as fast as thiopental. Thiopental is a little bit faster, and it's a little bit more impressive in the sense of how much more blood pressure drops you get with pental. But propofol is one of those interesting agents that it is very rapid acting once you give it enough of a dose. The equivalent that you'll see is when you're looking at a 1.5 to 2.5 milligrams per kilo, you're up in the higher end of thiopental doses, which is a 4 to 5 milligram dose, and associated, it's a 1.5 milligram per kilo of methotrexate dose. Now, the commercial preparations really have changed over the years. The first commercial preparation of propofol was available in Europe. It was with Cremophor. They had a lot of problems with it in the sense that they had allergic reactions and anaphylaxis with it. So at that point, they thought the drug was going to go off market and not be used at all. And then somebody decided, out of the blue, to look at another thing that was being used very frequently in the ICU in those days, which was called intralipid. Intralipid is actually a way of nutritionally providing people with fats in the ICU. So you actually do that all the time. If you worked in the ICU and you were giving TPN to somebody, you would get the intralipid up and you hang it on and infuse it to the patient to give them additional fat for their calorie counts. Well, somebody decided, well, let's mix this stuff and add the propofol to it. So what they made is a 1% solution. The initial solution, believe it or not, was a 2% solution, which was 20 milligrams per milliliter, which was way too potent. So they dropped it down to a 1% solution, which now contains 10 milligrams per cc. So almost all propofol that you'll see used in the United States is 10 milligrams per cc. When you actually look at it, propofol by itself, the medication, is an oil. Okay, it's actually a pretty viscous oil, and it has a yellow color to it. And I'll show you what happens when certain things occur. But propofol in itself is an oil. As a consequence, if you were to give straight propofol, it would be extremely painful to the patient, and it would not mix very well with the blood because it's not, that's more water content. So the emulsion was made to carry the propofol embedded in it. Okay, so the intralipid is composed of basically three major components. It contains 10% soybean oil, which is 100 milligrams. It contains purified egg lecithin, which is 12 milligrams, and it's got glycerin, which is about 22.5 milligrams. Now you have to ask yourself, well, why make that mixture? And I'll show you that in the picture next slide. In addition to that, they added something fairly recently. When propofol came over in the intralipid to the United States, they had several cases of deaths from bacterial contamination. Intralipid is notoriously great for bacterial growth. Okay, it has not only fats, but it has some kinds of metal cofactors in it that bacteria just love to eat. So it's not a safe thing to use if you're drawing it up and you contaminate the vial by accident. Well, the bacteria will go in pretty quick. They also had, inside the factories, they had trouble keeping everything perfectly sterile, and if they had just one bacteria get into the bottle, this is all it takes, by the time they got it delivered to the clinical sites, it was full of bacteria and caused a lot of problems. People were dying from septic shock from it. So because of that, they added an antimicrobial agent, which is benzyl alcohol. So you see that it's added on there, okay? It tells you right there, contains benzyl alcohol, okay, which inhibits growth of bacteria. Okay? And then the last one is more of a stabilizing agent to normalize the pH, which is sodium benzoate. Now, the intralipid, which is a white appearance that you see here, this is a typical bottle of intralipid that you would see in the ICU, is basically a two-part component. It has water in it, okay? And the other thing it has is fat. And it's mixed together in a way that the fat stays suspended. Now, let me just give you an idea what we're talking about, what an emulsion is. If you look at milk when it comes out of the cow, real milk, if you were to let it sit for a while, it would immediately break apart. And if you let milk sit for, let's say, 6 to 8 hours, the top layer will be all the cream layer. Okay? And then you'll see that it becomes more liquid as it goes down to the bottom. So fats will actually float on the surface of water. Well, imagine doing that with this stuff. That would not be good. Okay? So what they did was they combined 3 different kinds of fats together, which is soybean oil and egg lecithin, and they made this kind of little missiles, which means they're little globules, that hid the fat inside that was hydrophobic, and the outside layer was hydrophilic, or loving. So as a consequence, it then allowed these little vacuoles to stay suspended in the water. So they became like ions. They actually can stay in the water because they're charged. So this emulsification droplets is really kind of a key to understanding how this stuff actually works. Now that's considered, when you're talking about how the fats have been put together to form this vacuole, we call that a discontinuous phase. The reason it's discontinuous is because it's a combination of different fats put into an area. Okay? The actual discontinuous phase is what contains the propofol. The propofol is embedded in the middle of each one of these little spheres. Okay? And around them is the water that's suspending the little spheres. So the actual discontinuous phase is actually the smallest volume of the total liquid. It's not the greatest amount, it's just the smallest amount. What actually gives the color that you see has to do with the actual size of the actual vacuoles. of the actual fat spheres. The bigger the sphere is, the more white it is. If you can make a sphere really, really, really small, the color will become transparent because it won't bounce light off. Okay? So you'll actually get a more of a transparent appearance. The continuous phase, of course, is the actual water content. It has very, very small amounts of dissolved propofol because propofol is mostly oil, so it doesn't like getting in there. But it is the greatest amount of volume in the total liquid. So what you see mixed is they mix this oil and water, and then they cause an emulsion effect to take place, and these vacuoles form, and they stay suspended inside the solution. Now, already you can tell there's going to be a problem with this, right? If you leave milk sitting around too long, it's going to break apart. What do you think is going to happen with propofol if you give it enough time? Is this a thermodynamically stable molecule? I mean, system? It's going to try to go to bigger molecules. It's going to try to come together. And that's one of the problems with it. After about 2 years, pretty much all propofol goes bad. So you need to keep that in mind. Now, the emulsion droplet size is critical, okay? And this is another area that's very important clinically. People are finding this out the hard way. I've just been seeing some crazy stuff I've been reading about recently. Some people are actually taking stem cells out of people, and then they're injecting it. They're laboratorily working on it, and then they're injecting it back in the patient. Well, what they're doing is they're injecting fat globules back into these individuals. What they're not understanding is that the size that they're injecting back in is huge, and they're causing microembolization, and it's killing these people. Okay? So in our job in anesthesia, we've learned this a long time ago that you cannot give large emulsions with large droplets because you will harm the patient. Okay? So what we try to do is we try to find a happy medium that allows these carriers to go through all the blood vessels, including the capillaries, without any problems. And really the size that we are using is the fine macroemulsions, which is down here. So we're using the propofol size droplets are about 0.15 to 0.3 microns, which is about the same size of the naturally occurring chylomicrons in your body. So as a consequence, they don't beat up, they don't cause problems, and you don't get embolization normally in people that you're managing. Now, does that apply to all situations? And the answer is no. The smaller the actual animal or the smaller the human being you're giving it to, there may be a possibility that these chylomicron sizes begin to coalesce and may cause microembolization. And that's why propofol is really not indicated in small kids in intensive care units, because they may start getting these really bad side effects. Okay? The other thing that you have to understand is that the particle size matters in also the delivery of the molecule. The bigger the molecule, the bigger the lipid carrier, the bigger the vacuole, the medication you can stuff in there is greater. But now the distance for the molecule to move from the center to out increases, and as you make a sphere bigger, the surface area decreases dramatically. So if you're using these coarse macroemulsions in comparison to the fine macroemulsions, which is what we use, you can almost get a 44 to 50% increase in surface area by going to the smaller vacuole. And as a consequence, the medication is able to come out much more rapidly and have an effect. They found that out initially when they started doing this. They were using the molecules, the vacuoles were a little bit too big, and the propofol wasn't working. Okay, it was being very delayed. It just wasn't getting out of the actual emulsion. So our new, and that's something you have to understand, because when we take the medication and we let it sit, what does it do? It starts beating up. Okay? So what you should do, and I'm not just as fault as anybody else because they don't tell you enough of this, is you should shake the drug before you use it every time. It's like a little protein shake, that you want to have. In the morning, you don't want to have it just with the big globules that taste horrible. You want to shake that stuff first. Okay? It's the same kind of idea with this. You've got to shake it before you use it. Okay? So how does it actually look? What does a vacuole look like when you actually look at it under a microscope? Okay? And what you'll see is the inside here, which is, it should be more red than it showed up. It's in my slides better. But inside here is the red area. This is where the soybean oil is at. The soybean oil is made up of linoleic acids, okay, which are mostly straight-chain hydrocarbons that don't have any kind of charge to them. So they are hydrophobic. So the soybean oil is what forms the middle of the vacuole. This is where all the bulk of the diprovan or propofol is at. The propofol embeds itself inside this layer. The nice thing about soybean oil is that when they added it to it, they found that when they gave it to a patient, it had a very profound improvement in onset. And they suspect that is because the soybean oil protects the propofol from being uptaken by the lung on the first pass. The lung really consumes a lot of propofol. Okay? It doesn't metabolize it, but it uptakes it. It pulls it in. So by avoiding that, now you get a better distribution to the brain and get a much better effect. The soybean oil also sort of forms a nice vacuole size appropriately, very quickly. It's considered the hydrophobic area or the lipid area. Now the next picture is what we add egg lecithin. Egg lecithin is the white stuff in the eggs. Okay? And what's most likely what gives the color or the whiteness to the propofol. And what's inside the egg lecithin is many different kinds of fats. But the fats that we are interested in is the phosphorylated fats. Why would you want to have phosphorylated fats? And the answer is because it's charged. It's negatively charged. Okay? So all the phosphatidylcholine, all the phosphatidylethanololamine, and the phosphatidic acid, all these contain charged states which now line on the outside and actually help stabilize the suspension. So now you're forming hydrophilic vacuoles that can stay suspended in the water. If you did not add the egg lecithin to it, very rapidly the propofol would crack. Not sure what that means. The actual vacuoles would come together because the soybean oil would want to come together because they're all hydrophobic. Okay? But by adding the egg lecithin, you basically reduce the interfacial tension and you give this very nice characteristic to the vacuole. Okay? Does that make sense? This is the actual phosphatidylcholine. If you look at the molecule down here, look at the molecule down the bottom here. Okay, that's the phosphate group that's charged, and that gives it the negative potential, which is why it gives it a hydrophilic ability. And you have glycerol. Glycerol is an interesting compound. It's used in a lot of different things, in medicine as well as in other kinds of industries like shampoo. It basically helps maintain the formulation isotonic with blood. So it's a very simple compound that has a slightly yellowish color to it. And I'll show you how that will be more important as you go along. Propofol stability, you're looking at about a shelf life of about 2 hours. And you should store it properly between the temperatures of 4 to 22 degrees Celsius, which is one of the things that concerns me. When propofol is transported around, these trucks not necessarily are cooled. So sometimes you'll get a bad batch of propofol. The batch of propofol that you get doesn't seem to work very well. And then at certain times of the year, propofol is just like you give the same apparent dose, and now you got a super effect. And that can be an issue at times. So you got to be careful and watch for that. Okay. Now the other thing that I would highly recommend after reading all this stuff is that you should shake the propofol before you use it. Okay, every time. Because what ends up happening is you have this dispersed state, but after a while it becomes to flocculate, which means that the missiles begin to attach to each other, and eventually they coalesce. And when they coalesce, you start getting what's called creaming, which means it starts pulling away, just like the cream in the milk that I explained to you forms at the top. Okay, and eventually, if you wait too long, it cracks. If it cracks, it's irreversible. You can't really revert it back. At that point, then the propofol is broken out of the solution, and you'll see that you'll see a separation. You'll see an oil layer inside your Diprovan. Okay, I'm not a real fan of pre-drawing medication. Okay, and that's one of the things we're going to stress on you a lot. Do not draw what you don't need. Okay, it does not make sense to draw up 7 vials of propofol in the morning. It is such a waste of money. Okay, and also you're risking that person's life that you're going to be administering this drug to, because they can have bacterial contamination. And even with the benzyl alcohol in it, it doesn't mean that you can't get growth. It just inhibits it. So you can actually kill somebody by giving this stuff to them. Okay? The other thing that I would worry about is over time is that when you take it out of the vial, as soon as it gets re-exposed to air, there's more chances of having problems with this cracking and coalescence taking place. And the other thing that's a concern is that it does two things. When it starts becoming coalescing, it starts decreasing the potency of the propofol. So shaking the propofol beforehand may actually enhance your potency. Because remember I told you that if the missiles get bigger, the propofol can't come out, and the surface area drops. And the other big concern is that it may cause embolization in patients. Now, your propofol emulsions, because of this bacterial concern, they started adding a lot of stuff to it. They started saying, well, what is the proper stuff we should add to stop or eliminate the bacterial growth? And the things that actually grew out are pretty nasty stuff. Things like Staph aureus, E. coli, Pseudomonas aeruginosa, and of course your Candida albicans, which is not a bacteria, but it can hurt you just as well. Okay? What you see is that they used all these different things in the bottom of additional preservatives to try to prevent bacterial growth. The first one that they used in the United States was EDTA. What EDTA does is that it binds to factors, metal factors that are in the solution, and prevents bacteria from using it. So they don't have these cofactors that they need for survival, so they won't grow. The one that we use is benzyl alcohol mostly, and that basically is an inhibitor to cellular growth. So, and the other one that you'll see a lot being used by some places is the sulfite. Sulfite is a compound that it forms sulfur dioxide gas inside the Diprovan. And some people that are allergic to it can have anaphylaxis to it. So these preservatives, which you think that don't have any effect, actually in some people you can have big problems with. And of course, patients don't necessarily know that they're allergic to sulfite or EDTA. So you just got to be careful when you're going to different areas or different hospitals. Look at the propofol you're working with and see what they have in it as a preservative. We have in our preservative the actual benzyl alcohol, which tends to be more innocuous, and other centers will have sulfite, which I'd be concerned about because that one does seem to have more of an allergic potential. Propofol emulsion compatibility, don't mix with lidocaine. Some people used to do this quite often. Lidocaine has an altered pH. It alters the missile, and it begins to coalesce much more rapidly. So if you do want to use lidocaine, which some people still won't, they just don't realize that you can separate out, give the lidocaine first. Instead, they mix it together and then they give it together. The issue with it is that studies were done to decrease pain on injection is they would take a tourniquet, just use a little rubber band, put it around the arm, okay, and they would inject 100 milligrams of lidocaine IV, and then wait 30 seconds. That was a real study that was done. Okay, well, the lidocaine numbs a vein. Okay, it's just like what we do for a beer block. Okay, and then you take the tourniquet off, and then you inject the Diprivan, and it doesn't hurt at all. Well, everybody said, well, we'll just do it faster. We'll give the lidocaine, and then follow it with the Diprivan. Well, it doesn't work that way. Okay, even when you give lidocaine initially, if you don't put the tourniquet up, it flows through too fast, and now the person still perceives discomfort. So the next thing they said, well, let's ameliorate it by combining the two together, and we kept bastardizing the way it was done, and eventually now it doesn't, I've seen people say, well, it works. I said, well, it works because you're using a larger cannula and a big vein up top, so it appears to you that it works, but when you put it in a little vein, you're going to find out it's very painful no matter what you do, unless you do the lidocaine technique where you put the tourniquet up. So, the big danger about giving lidocaine together is that it begins to cause the medication to crack. That's not good. Okay? And it may cause embolization. So for that reason alone, I'm not a fan of doing this, and I tell people, please don't do that when I'm practicing with them. So as long as that happens, that's fine. I think otherwise you're asking for a recipe for disaster. Okay? The other thing that you can get in trouble with is propofol and protamine, which is something you don't necessarily see, except in the heart room. Okay? In the heart room, we give protamine to reverse the effects of heparin. Well, if you would take the same line that the protamine was just given, and you hook up the propofol through that and infuse it, you will notice that the propofol immediately cracks. Immediately. It's really impressive. So because of that, you've got to make sure that you're using other lines, because you may be seeing large embolizations going to the patient from these large oil droplets that form almost immediately from the protamine. And so that's one of the ones you cannot mix, protamine and Diprivan. Okay? Where else is protamine found? Insulin. Right. Okay? So do not shoot insulin into your propofol line. Okay? If you are going to do it, you're going to have to go, you have to go off sub-Q, because you shouldn't be doing it. Not all insulin has protamine, but a lot of it does. Okay. Anesthetic properties. Diprivan is really an excellent hypnotic amnestic agent. Okay. It basically puts you to sleep very smoothly. It keeps you down, and you're basically unresponsive most of the time. If you're going for a lighter level of MAC, people will actually talk to you, but as long as you have nystagmus, that person is amnestic. Okay? If they're looking at you and their eyes are fluttering, they're amnestic. You could talk to them all day long, and they won't remember a single thing you just said. But they'll talk back to you, and they'll answer your questions. The danger of this agent, of course, is you can lose airway reflexes. And it's actually one of the most potent ones that decreases the incidence of laryngospasm. If you give enough of it, you can actually intubate somebody without any muscle relaxation in fairly good effect. And we do this quite often with kids. It has no analgesic effects at all. Okay? That's important. Never think that Diprivan has analgesic properties. Now, when you read it in textbooks, or you actually read some of the initial studies back in the 93 and 95, they felt that Diprivan had a little bit of analgesic potential. And I will tend to agree that it has a little bit, but a little bit isn't a knife put to your skin. Okay? A little bit would be maybe putting a needle into your skin, and somebody would not notice that much. Okay? But if you put a scalpel to the person's skin, and you don't have any additional narcotic on board or some kind of analgesic on board, that person is going to come right off the table. Okay? That's why it's critical. If you are going to use MAC, MAC is monitored anesthesia care. And you really have to have a regional anesthetic or a local infiltration for the person to tolerate it. If you're doing it combined with additional opiates, then you're decreasing the safety profile of the medication. Because as soon as you add the opiates to it, you're actually increasing the risk of doing the procedure. The person is more likely to get apneic and have other problems. Propofol also has no muscle relaxation properties. It does decrease autonomic suppression. So it does decrease the autonomic nervous system to a certain degree, but it can be fairly easily reversed with a painful stimulus. What's really nice about propofol, and compared to any other drug that we have, is that you get super rapid awakening. Okay, and it's very complete. People, after an endoscopy, they don't look like they've had anything. They can go home and they'll tell you, I want to drive home, I feel great. No, you're not allowed to drive home. 24 hours you're not allowed home. Okay? So, you think about it. We're doing everybody at about 10 o'clock in the morning. The next morning they're up out of the house at 7 o'clock. They didn't wait to 24 hours. Okay? But we're supposed to tell them for 24 hours not to drive. By that point, the drug's completely out of the system, so it's not an issue. And if you see how many people are driving around with Ambien post the next day, I mean, come on. This stuff is innocuous in comparison to some of the stuff that people are taking over the counter. Anyways, it has minimal residual CNS effects. The other nice thing about propofol is an antiemetic, and it's also an antipruritic, so it decreases the itching. It's actually pretty helpful in patients that are getting neural actual narcotics. It does not cause MH activation, does not affect steroid synthesis or ACTH response, which we'll talk about later on about etomidate. Does not alter hepatic or the fibrinolytic system. Does not cause histamine release. And the context-sensitive half-time is minimally influenced by the duration of infusion. The only one that's actually better than Diprovan is etomidate, okay, which unfortunately we can't use because of the adrenal suppression for long term. The mechanism of action of all these agents, at least for etomidate and Diprovan, is its GABA activation. So it has a very exerts GABA agonist activity and increases the transmembrane chloride conduction, very much similar to benzodiazepines and barbiturates. They actually are working in the same receptor site. They hyperpolarize the postsynaptic membrane by this increase in chloride concentration, and they basically functionally inhibit the postsynaptic neuron. It also does another thing, which is similar like the etomidate, which is it enhances the agonistic effects of GABA. So the normal GABA receptor being released by your brain, when propofol binds to the site, it increases the duration of the GABA staying on the actual site. It's called the potentiation effect. If you look at the pharmacokinetics, it has a short effect site equilibration, which means it has a very rapid effect. Okay, but what terminates the action of Diprovan is not metabolism, but redistribution. So it's just like any other drug that you want something on and off. The first one that actually did the classical redistribution thing was barbiturates. Then we followed with the benzos. Now we're following with Diprovan. We're going to find out the same thing with etomidate. They're all redistributing. That's how they're coming off. And that's a benefit to us because you can have rapid awakening. The medication continues to be eliminated by the liver, and it takes elimination in half-time, about 0.5 to 1.5 hours. Your context-sensitive half-time, which you'll see in the next slide, is after about less than 40 minutes, you really don't have too much problems, and there's no evidence of impairment in elimination in patients with cirrhosis of the liver or renal dysfunction because you have extra hepatic sites where metabolism is taking place extensively. Tissue uptake, possibly into the lungs, is the most important for removal of this drug from the plasma, which is what we call redistribution. The clearance from the plasma is rapid, okay, because the medication goes to fat and muscle very easily. And definitely the redistribution is much more important as it exceeds metabolism. You have a hepatic blood flow that's not as important as redistribution. Basically, the hepatic metabolism drives it to an active metabolite is rapid and extensive. And actually, less than 0.3% of the medication goes unchanged in the urine. So pretty much it's all broken down by the liver and by other areas as well. Okay. Clearance is affected by increasing age. People have increases volume distribution, increased fat content, and as a consequence, you have to reduce your dosage on propofol as you get older. The metabolism of propofol is that it's broken down by the liver and other extra hepatic sites it converts it via glucuronidation and sulfation, okay, which makes it water soluble at that point. and then the urine can get rid of it. The glucuronidation is the same thing on the other side. So it does it extensively. Clinical uses, propofol, MAC is really it's a very strong point. It's one of those medications you can actually start and get a very titratable effect that you want to have. The context-sensitive half-time is great, so you don't get accumulation effects. So you have a pretty effective end of response. Okay. The problem with this is that MAC cases, the person should be arousable, and you can pretty much easily push them over into a general anesthetic state if you're not careful, and then they go into apnea, and then you're in trouble. The other thing where you can get in trouble with this stuff when you're doing MACs is if the surgeon doesn't really understand that propofol is not an analgesic, which a lot of them don't. They think magically when we give this drug that it's like an opiate. They don't understand that it's only selectively giving you amnesia. So when they put the local anesthetic in, they don't wait enough time or they don't put enough in. So when they make the incision and the person starts to move, you're immediately blamed because you didn't give enough. Well, yeah, I can give more and the person won't move, but they also won't breathe. Okay, and they'll be nice and dead. So, you can't do that. So what you have to sort of keep reminding the surgeon, you might want to inject more local. And I'm actually pretty vocal with the new surgeons when they come into town, because they always play this game when they come out of residency. They think that we don't know what we're doing. And you got a gray-haired guy like me at the back end of the machine. And I look at him and said, "Son, you want to give some more local?" And usually they'll look at me like, "Oh, okay." So I'm not giving any more. So they give more local, and all of a sudden everything gets smooth. And he goes, I just go, the thumbs up, good job, And after about 3 or 4 times of doing this, they realize this guy's going to be a pain in the butt. He's going to ask me to put more local in because he's not giving more. And they realize I'm not willing to put the person at risk just because of their inability to put local anesthetic. I had several cases when I was a resident where surgeons wanted to do a new way of doing breast mastectomies under local. Okay? Well, I did 3 of them that way, and the 3 cases were just a disaster. The patients were constantly moving. They were trying to get out of bed. They just wouldn't see me tolerate it. So the 4th time, I didn't tell them what I was going to do. I put up the blue screen. I said, "Okay, we're ready." The surgeon started cutting, did this whole thing. They finished the case. They go, "That was the best anesthetic. They didn't even move at all." I dropped the screen down. The patient was intubated under general anesthesia. They looked at me like, "Oh." I said, "Okay, because I'm not doing it any way your ways anymore. I'm done. Okay, we're doing it general. That's what it's for." Okay, Diprovan is not for big, massive procedures. It is as long as you can do local and regional, but it's not appropriate for doing a general anesthetic alone, unless you're adding fentanyl and all this other stuff to really increase your depth of anesthesia. Really important for understanding. Okay. Now, as for induction agent, Diprovan is the induction agent of choice right now in the United States. It's becoming much cheaper. Okay. It used to be ridiculously expensive compared to pentothal, so we used to use pentothal, but now pentothal is not available. But now the continuous actual induction agent is very smooth, and when you give it as 1 dose, you get a rapid awakening within 5 minutes. Pretty reasonable. You can also give continuous IV infusions of propofol, which we use quite a bit for IV conscious sedation, as well as TIVA. Okay? But TIVA is basically several things. TIVA should be Diprovan, fentanyl, and some form of muscle relaxant. Because what do you have? What do you need for anesthesia? You need 3 things. You need amnesia, analgesia, and areflexia, and autonomic control. That's the 4 major things you need. Well, Diprovan gives you only 2, so the other 2 have to be covered by something. A lot of us with TIVA don't feel comfortable completely with TIVA. Okay? I personally don't feel completely comfortable with TIVA all the time because I've seen an IV infiltrate, and then you're having a patient wake up in the middle of procedure. So I really don't feel comfortable with that. So what I always run is when I put somebody under TIVA, under general anesthesia, is I use nitrous oxide to make sure that the person stays amnestic, okay, with minimal effects. As long as you stay at 50%, your nausea vomiting rate has been not a problem. If you look for ICU-wise, it's also used in ICU sedation. I personally thought that was really a bad idea because it's so expensive. The other thing that's a problem with it is that in pediatric cases is it causes lipemic plasma. And I actually saw this one time. They actually drew blood from a kid, and I was standing beside him, and they've been running the Barbiturate for about 48 hours. And I looked at the blood, and the blood was all white. It looked like propofol. Okay, it was actually becoming lipemic, and the kid was getting acidotic and not doing well. And I said, well, this kid's microembolizing from this all this stuff. It's just accumulating too much. So we shut the Diprovan off, and the kid actually survived and did okay. But then we went out about, somebody reported about 6 months later that it's not good to use in pediatrics because these kids were dying from metabolic acidosis, bradycardia, and they had several events of sudden death where the heart just stopped, and they developed myocardial failure. So make sure that you don't give pediatric cases propofol long term. Induction, the normal induction dose should be 1.5 to 2.5 milligrams per kilo. The blood levels that you get is 2 to 6 micrograms per milliliter, and gives you great unconsciousness. In children, you have to up the dose to around 3 milligrams per kilo. Make sure that you understand one thing. If I put it in green, it's a test question. Okay? That's why I did that. Okay? I expect you have to start learning the dosages. Might as well start learning them now. Okay? So 1.5. If you don't have to memorize the whole number, just memorize 2. 2 milligrams per kilo, induction dose. Okay? If you're doing a child, you should be at 2.5 to 3 milligrams per kilo. If you're doing an elderly, you should be at 1.5 milligrams per kilo. Okay? You should be going down. Okay? So the reason that children require higher doses is they get higher central distribution volume and a higher clearance rates. The elderly, on the other hand, have smaller central distribution volume and decreased clearance, so you need to reduce your dosage by almost 50%. When we're doing endos and stuff, I will tell you, give a little bit and see what happens. It's always better to just give a little bit because on elderly people, you might be surprised how far it goes. Intravenous sedation with propofol is easily titratable, has a short effect site equilibration and short context-sensitive half-time, which makes it ideal so you don't have accumulation effects over time. It's ideal for ambulatory conscious sedation due to prompt recovery, low residual sedation, and low incidence of nausea vomiting. The typical conscious sedation doses that we're giving this is another important number. When I tell you I want you to sedate somebody, that means the number has to be at 25 to 100 mics per kilogram per minute, between that value. If you're up to 150 mics per kilogram per minute, okay, and you're doing conscious sedation, no, you're doing general anesthesia. And you're doing general anesthesia because the surgeon has not put any local anesthetic. And that's the only way the person will tolerate it. But now you're on the general anesthetic state with all the risk associated with it, and you're trying to run it without an airway. Very high risk stuff. Okay? This is what's killing people in plastic surgeons' offices. People think that, okay, well, you know, propofol is great, so I'll just keep increasing the dose till I get somebody to stop moving. You will, but then if you don't have an established airway, you will be in a lot of trouble. And people get hypercarbic and they get all sorts of trouble with it. Be careful when you supplement. When you give midazolam or short-acting opiates to that individual, you get a significant potentiation effect of the Diprovan. Now, here's what this is not in the book, this is something I want to show you, that I look at the drug. Okay? I truly believe that Diprovan works by what's called a top-down effect. It basically goes to areas of very high blood flow. So this is observational clinical anesthesia at work here. Okay? When I give Diprovan, the first thing that you see is that the cerebral cortex goes out. If I tell people that are mathematics experts, please add 2 plus 2, 4 doesn't come back. Okay, it's 5, 3, or something else, but it ain't 4. Okay, so right away the cortex, or the higher brain function, goes out, even though the person's talking to you. You know, I've had this, I've actually shown this to students. You can sit there and keep talking to the patient, and they start telling you all their stories or They tell you stuff that they really shouldn't be telling you, okay? And you can actually interrogate somebody, and they would never know you asked them. Okay? But don't do that. It's not considered correct. Okay? Don't let their husbands ask them questions while they're being sedated. It's not appropriate. Okay? Anyways, the next thing that happens is the medication goes down further. It starts knocking out the brainstem. And it seems to affect the brainstem by levels. Okay? So the first thing you'll see is you look at the eyes and you get eye sign changes. You get oculomotor reflex problems, so the person gets lateral nystagmus. So when you ask them to look to the side, the person will have a gaze that quickly jerks back to the middle. It's like watching a little ball bouncing on a little string. It's very strange how people look that way. But at that point, you know that person's amnestic. Okay? And one of the things I teach you guys when you're doing bronchoscopies is that's the level I want you to stop. That's all you need for bronchs. If you go any deeper than that, you're going to suppress the laryngeal reflexes, and then when they put the scope through, then the larynx above is going to collapse on them, and the person's going to desaturate like a stone, which is what you want to avoid in bronchoscopies. And endos, on the other hand, I want them to get this big scope through, and even if they touch the vocal cords, nothing bad's going to happen, so I want them a lot deeper. Okay? 2 different procedures. Okay? Now, because you knock out the cranial nerves 1 through 4 very early, the vision goes out quickly. Most people that at this point can't remember it anyways because they're already amnestic. Okay? But people, you'll see that you put your hand in front of them and they won't react to your movement. Okay? Even if you try to open their eyes, they just don't react to visual stimulus anymore. And they will usually begin to close their eyes. The next thing that goes is your auditory. It's pretty late to go. And then when you get down to the actual medulla oblongata, when you give enough of a dose, you get what I call the yawn of death. Okay? What the person will do, they go like, okay? And then they stop breathing. And it's really like, you just see it. Nobody has written about it, but I can just tell you, we see it all the time. And when you see it being for MAC cases, and you see that yawn, your fear level better go up. Because if you didn't check the airway, and you were sure that you were never going to get to the point where you over-sedated the patient, well, you just reached it. Because that person will be holding their breath from that point on. Now, is that reversible? Yes. Pain will reverse it. Pain will drive you back up to a point where you will breathe. Okay, so what you can do is you can take your 2 fingers and jam it behind here, behind the mandible, and push the mandible forward. It opens the airway up, but really what you're doing is you're inducing a tremendous amount of pain. You're actually compressing on the retromandibular nerve, and that is something that is not nice. Okay? We think that's part of the reason that people get knocked out when somebody punches you in the jaw. It causes a rapid nerve conduction up the retromandibular nerve, and it puts you out. So it's pretty painful. Okay? So what you get, though, as soon as you also knock this out, this area, is you knock out the vagus nerve. So again, what the book says it causes bradycardia, but it doesn't initially. Diprivan actually causes tachycardia initially. The heart rate goes up. You know? And they say, well, why does it? Well, because you're knocking out the vagal nerve first. As Diprivan continues to circulate now, it goes to other areas that are less blood flow. Okay? And they are the areas that are less blood flow in the spinal cord. So the next thing you'll see is that it goes to the spinal cord and knocks out the cardiac accelerator fibers. And that's when you get the bradycardia. And sometimes it can be profound. Okay? And some people it can cause death. So it decreases your sympathetic tone. It's a preload reducer as well. So one of the things that I want you to understand is that when do you put an LMA in somebody? When should you put an airway device into somebody? Should you just wait till the heart rate starts to zoom upwards? Is that enough? And my answer is no. That's not when you put the LMA in. You wait till the spinal cord gets knocked out. As soon as the heart rate begins to drop, That's when you put the LMA in. Because now, when you put the LMA in, there's no more reflex. The airway reflexes are gone. The sympathetic reflex is gone. So when you put the LMA in, now the person doesn't react. Almost every student that I've seen, because they're so excited, they're so driven to get this airway device in, as soon as a person closes their eyes, that's good enough for me, baby. Okay, let's jam this sucker in. Okay, and especially if they help out by yawning. Now it's already open for you. Just stuff it in, right? No, wait. You need to get them to an unconscious level where they're deep enough and it's safe to put this huge device in. Okay, so that's one trick. If you don't do that, you will find out the bad ways that you'll get hiccuping. The person will go in laryngospasm. The person will start trying to tongue the LMA out of the way. Won't tolerate it. So don't do that. Wait till you're deep enough and get the bradycardia slowing down, at least beginning to slow down. That indicates to you that you knocked out everything and you can do the case. You have to get really used to using these infusion pumps. This is a Baxter infusion pump. Okay. The beauty of this pump is that it's got a peel-away surface that's made out of a magnet. So every time I want to change the drug out, I can peel away and get a new one up so I can infuse many different medications. This is actually considered old technology now. Okay? The newer technology is TCIs, which is targeted continuous infusions, which is a little bit too much for today, so I can't go over that, but it's another area. Okay? What we do with general anesthesia is we up the dose. Now we're up to 100 to 300 mics per kilogram per minute. So now, if you're up to that level, you're under general anesthesia. If you're doing an epidural or spinal for a joint, okay, and you notice that you're up to 150 mics per kilogram per minute, and that's the only way the person stays still, what does that mean? Your spinal doesn't work. You're basically inducing a general anesthetic state because your spinal is patchy. It's not working properly. Okay? Because it never surprises me. I had somebody the other day who was at 250 mics per kilogram per minute, and the CRNA was sitting there watching with him, and I walked in, I looked at him, and was like, geez, gentlemen, what do you think? And I said, well, we're not sure, Doc. I think just is a lot of Diprovan. I said, how about we try this real quick? I shut the Diprovan off, and then the screaming started. So we should put it back on. I said, I think you need a general anesthetic. And we put the guy to sleep, put an intubatum, and moved on. Okay? You really have to understand that if you're up to that high levels, your regional has failed. Okay? And you then have to prepare for it. So, at the end of the case, you dose the person with narcotics, keep them comfortable. Or if you want to reconsider, you can do a femoral block or do something else for them to keep them comfortable. Because at that point, your regional has failed. The benefits of propofol general anesthesia is minimal postoperative nausea, vomiting. Awakening is really prompt, and you have minimal residual effects. The non-hypnotic applications as an antiemetic has decreased the incidence of postoperative nausea, vomiting. You can also give subhypnotic doses of propofol. I'm not a real fan of this, but my friends have done this before. When somebody hits recovery, they just pop them with a 10 milligram dose of Diprovan if they're nauseous, and it takes away the nausea. The reason I'm not a real fan of this is because, sometimes 10 milligrams will go a long way when you have a lot of narcotics on board, and won't act like it should be. So if you are going to do this in the post-op area, make sure that you're monitoring that person extensively, and make sure that you have airway devices just in case something goes wrong. It's also been used as an effective treatment for chemotherapy-induced nausea, vomiting. It just basically stuns the individual. The actual person's looking at you, but that's, again, I think you should have to be very careful. It's effective in the treatment of pruritus associated with neuroactional opiates. Again, it's something I wouldn't recommend on the floor because, somebody starts the Diprovan drip on the floor without an ICU stay, you're asking for trouble. It's also propofol is a secondary agent to terminate convulsions or seizures. It's actually been used to terminate status epilepticus. But again, it's not a good idea in the unit because they've actually had an increase in mortality associated with it. You're having to give much higher doses of it because in such a short termination of action, it goes away. And it does decrease the seizure duration, so it's not the ideal agent for somebody undergoing ECT therapy. So I don't use Diprovan for ECTs. I use methotrexate. Basically, it does not induce seizure activity in epileptic patients, which is good. But occasionally, you'll see myoclonus. which is not as severe as etomidate, but you do get myoclonus actions. Propofol's effects, I think I'm running behind. So I'll stop here, give you guys a 10-minute break, and we'll start back up.